Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned professor, Dr. Ketan Mehta. Sir is the MD Med, FCPS, IFCP, FIAC, and consultant physician at Mumbai and also a consultant at Health Harmony Clinic in Malad. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is lung in thyroid disorder. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin with. Over to you, Sir.
Yeah. Thank you. Thank you so much. Very good evening to one and all those who have joined. It's indeed my pleasure and honor to be associated with IJCP, whom whenever, it just gives me my relation with IJCP, which is last so many years, and it always reminds me my beloved friend, late Professor Dr. KK Agarwal, with whom I have worked for so many years across the board for various webinars and physical meetings. So, friends, what I'm going to discuss today is lungs in thyroid diseases. And you would be wondering what lungs has to do in thyroid diseases. And in fact, this was the topic given to me during the last Epicon 2023, which was held in Ahmedabad. And there I realized that, there are so many things which, by way the lungs gets affected in various thyroid diseases. So here it reminds me a beautiful quote for Sir Isaac Newton, who states that what we know is a drop, what we don't know is an ocean. And that is so much true when we start realizing or discussing about lungs in thyroid diseases. So, what I would be discussing today is the initial introduction to the subject. Then I would discuss about hypothyroidism and associated respiratory symptoms. Then I will discuss about hyperthyroidism and respiratory symptoms. Then about the thyroid cancer and the lung involvement. I would also be talking about goiter and airway compression, and of course, then finally summarizing, and then we will take up the question answers if there are any. And I'm sure this would be of your interest in your clinical practice, because the if you really see, the thyroid is one of the commonest condition which has been prevalent within all specialities, whether we talk about family physicians or whether we talk about the specialty medicine practice, so be it in cardiology, endocrinology, diabetology, hematology, gastrointestinal system. So it has a role in each and every system, and probably by learning about these correlations, I'm sure it would be in a much better way we can understand the subjects very clearly. So, talking about the introductory part, we know that thyroid hormones have complex metabolic effects, and that explain their intervention in complex mechanism of respiration. I am not going to discuss about the role of thyroid hormones in other system or what is their role in each and every individual system. But what is more important today, we are going to learn about their effect on respiration. So thyroid hormone regulates protein, lipid, and carbohydrate metabolism. So that means all major macronutrient metabolism are being governed by thyroid. It also controls the membrane enzyme activity. It increases mitochondrial oxidative processes. It modulates the transcription of many genes encoding the myofibrillar and calcium regulatory proteins in myofibers, and overall it play an important role in the development of the lungs and maturation of pulmonary surfactant. So, if you see right from cellular level, structural level, or functional level, it has a effect at all these levels and plays a very major role in the development of lungs and hence the thyroid hormone and lungs. There are a lot of things which interplay and we must understand that. So now let us look about pulmonary manifestations of hypothyroidism. If someone asks you what are the common manifestation of hypothyroidism, then you will feel, "Arey, what pulmonary symptoms are there?" Commonly, what you get is a weight gain, fatigue, lethargy, lower BMR. So these are the common manifestations which are there. But friends, don't forget, so there are pulmonary manifestations of hypothyroidism, and why we are discussing today that if you get such manifestation, you must think about hypothyroidism in those patients also. So first to understand that, which we must understand why there are these pulmonary manifestations occur in hypothyroidisms. And then there are several pathophysiological mechanisms which has been postulated. So first is reduction in central respiratory drive. We know the overall body metabolic rate also slows down and the central respiratory drive also can reduce. Second, there could be a respiratory muscle weakness, especially in advanced uncontrolled hypothyroidism, and which could be due to a combination of myopathy and neuropathy. Then there could be a decreased lung compliance, which is also maybe a feature of hypothyroidism. Then, as you know, there is a serous collections in various serous cavities, so including the pleural effusion, which can add to the symptoms of respiratory involvement. Then there could be a manifestation of pulmonary arterial hypertension, and then there are sleep related the breathing disorders which has been described. So you have got the various mechanisms by which we know that there could be a manifestations of hypothyroidism with the lung involvement, which we have to keep it in mind also. Now, question always comes about, is there a data? Yes, when we speak about anything, always there has to be either it is a evidence-based medicines or endorsement-based medicine, or sometimes, of course, the experience-based medicine. So these are the three E's on which we talk about that what is the most important point and the points which are of relevance. Okay, so you must understand that severe hypothyroidism is associated with a marked depression in hypoxic ventilatory drive and hypercapnic ventilatory drive. So, what does it mean? That, in response to hypoxia or hypercapnia, the respiration or central respiration gets stimulated. But once you have a severe hypothyroidism, this response is blunted, and it is very well shown over here. So, if you see uh, this red line, which is a normal response. So, ventilatory response to hypoxia in patients with mild and severe hypothyroidism, that is the blue line. So, if you see mild, it is slightly altered, but look at in severe hypothyroidism, there is a blunted response. So, compared to normal population, there is a blunted response in hypoxia, in ventilatory response to hypoxia. And similarly, there is a ventilatory response to hypercapnia, if you see. So, if you see this red line, which is a normal response in the mild hypothyroidism, this is the response in severe hypothyroidism. This is the response, this is a ventilatory response to hypercapnia. So, the bottom line is that whether we talk about hypoxia or hypercapnia, the ventilatory response is suppressed or diminished, and as a result of which the person starts feeling fatigue or even a breathlessness, which can become more pronounced. Now, very interesting point to be noted. Once you have diagnosed somebody with hypothyroidism, the next thing you will do is correct it, right? So the correction is with levothyroxine. But remember a very interesting point, that the depression in hypoxic ventilatory drive, but not hypercapnic ventilatory drive, significantly improved thyroxine therapy. That means hypoxia induced stimulation got improved, but hypercapnia stimulated central drive did not improve even after the levothyroxine therapy. Now, this was something very, very interesting finding, and that is why we always try to see to it that these patients do not develop hypercapnia, because otherwise it will be really difficult to treat them. Now, when you look at the complete PFT, so there is a carbon monoxide diffusing capacity. So this is diffusing capacity for lung, which may be low, and it can increase during the treatment. So the question always remains why it is low. So the reason for the low DLCO, so diffusing capacity for lungs, which is not very clear why it is low, but and why it improves during the treatment. So that means there is some association with hypothyroidism which has been found, and over a period of time you will see that there is a improvement in DLCO. So here the DLCO in 12 patients increased significantly from a mean of 69 to mean of 93% of the predicted normal. I know, I'm sorry, the chart over here is showing a lot of figures and all. Don't bother about it. What is interesting to know, that improvement in DLCO happens with the therapy or correction of hypothyroidism. Now, similarly, respiratory failure, and this is a very, very important move which needs to be kept in mind by all intensivists, that hypothyroidism should be considered in a patients with respiratory failure who are difficult to wean. So we see so often patients who have gone on invasive ventilator, and over a period of time we start realizing that there had been a significant improvement overall in other parameters has improved. So obviously you start thinking, let me give a try and take this patient off ventilator. But if they are uncontrolled hypothyroidism, it will be difficult to get them off ventilator. So this is the point which has to be kept in mind. So in this study, 121 ventilator dependent patients, 4 were found to have severe hypothyroidism, and winning was aided by the treatment with levothyroxine. So once you give the therapy, then you can wean them up. Otherwise, it will be difficult to get them off the ventilatory support. Now, talking about the sleep apnea, I'm sure all of you are well versed about it. Hypothyroidism predisposes patients to sleep apnea. And sleep apnea, it can be either of central origin or obstructive in nature. So obstructive sleep apnea syndrome, what is called as OSS, has been diagnosed in 25% of patients with hypothyroidism. So it's a huge number. So one out of four hypothyroid patients has got obstructive sleep apnea. And on the other end, in 3.1% of OSAS patients, that is those who have obstructive sleep apnea syndrome, thyroid hypofunction has been detected. So it's a vice versa, that if you have OSS and if you check the thyroid status, the thyroid malfunction or thyroid hypofunction, which will be found in 3.1% of patient population. So, talking about obstructive sleep apnea syndrome, so there are risk and causal factors of OSAS in hypothyroidism, which has been thought of, and this includes there could be a ventilatory dysfunction, oropharyngeal and upper airway infiltration with mucopolysaccharides and protein deposits. There could be a respiratory muscle asthenia, obesity, male sex, and advanced age. So, all these will predispose them to the obstructive sleep apnea syndrome, and this association has been well documented, so which we all are well versed in. So, this is a typical polysomnography report in a patients with a hypothyroidism having central apnea. So polysomnographic, here you can see that multiple central sleep apneas which has been depicted, and then there will be a sudden arousals. So which happens because by that time the hypoxia sets in and the person gets aroused. So the only way to detect obstructive sleep apnea is getting the polysomnography done. So, uh, when we talk about severe uncontrolled hypothyroidism, we must understand that what is the mechanism of people going into the coma in a state of severe hypothyroidism. So, if somebody has got a low T4, which can lead to reduction in intracellular T3. Now, it has effect at various levels. It has an effect on fluid balance, it has effect on cardiovascular system, it has effect by reducing thermogenesis, and it has effect on CNS. So on CNS, there could be altered mental status, which can attribute to coma, decreased thermogenesis leading to hypothermia, and decreased sensitivity to hypercapnia and hypoxia, leading to respiratory insufficiency, leading to cerebral anoxia, and can add to coma. Now, in cardiovascular system, there could be a reduced inotropism and reduced chronotropism, which can lead to reduction in cardiac output and increased vasoconstriction, leading to low blood volume, leading to blood pressure, which could be varying, and leading to shock. So obviously, patient can end up with coma. And when we talk about the fluid balance, increased vascular permeability and increased water retention can lead to various effusions. So, as you know, people can have either pleural effusion, ascites, or pericardial effusion, and of course, there will be a dilutional low sodium which will be found in such patients. So, the most important is reduction in thermogenesis, which can contribute to coma. So, which is definitely a very, very important factor with the patients with hypothyroidism. Now, words about pleural effusion. Hypothyroid pleural collection, which is in small amounts, is less than one third of the pleural cavity. Unilateral or bilateral, serous or serosanguinous, transudative or exudative in general non-inflammatory, and it is asymptomatic. More rarely, it can induce restrictive pulmonary function. Its pathophysiological mechanism is unknown, and probably it develops through an increase in capillary permeability. So hypothyroid pleural effusion resolves by hormone replacement therapy. So like other symptoms, if you have somebody has got the definitely hypothyroid pleural effusion and you treat hypothyroid with levothyroxine, and you will see the effusion will get a result. Now, word about autoimmune thyroid disease. Now, it has been very interestingly found that significantly higher titers of thyroid antibodies, that is, thyroid peroxidase antibodies, have been found in women with than without asthma. So, that is one thing which is there. So, those with asthma will have more likely possibility that autoimmune thyroid antibodies, which we talk about antimicrosomal antibodies and anti-thyroglobulin antibodies, so that positivity will be higher. And it is possible that the association of Hashimoto's thyroiditis, that is autoimmune thyroiditis, and TPO antibodies with pulmonary symptoms may reflect a related autoimmune process that affects pulmonary function. So this we will have to keep it in mind, and probably we can take a call subsequently once we start evaluating those subjects also. So we had enough talk about hypothyroidism. Let's talk about pulmonary manifestations of hyperthyroidism, because though not common, but it is not a rare entity. So in hyperthyroidism, there would be an increased ventilatory drive. So hypothyroidism is associated with increased ventilatory drive in response to hypoxemia and hypercapnia. If you remember, in hypothyroidism, there is a reduced response, whereas in hyperthyroidism, there is an increased response. So, with exercise, hyperthyroid patients are more dyspneic than normal subject controls for the same level of work. So, whatever, even the slightest work, they will get fatigue. So, fatigue is a symptom which is common to both hypothyroidism and hyperthyroidism. Okay, and increased ventilatory drive seems to be account for dyspnea on exertion in hyperthyroid patients. So quite often they will complain it, and if you start evaluating lungs are normal, heart is normal, and you start wondering where is the cause. So this could be the cause. So the mechanism for increased ventilatory drive is uncertain, but beta adrenergic blockade reduces it to normal, suggesting that adrenergic stimulation plays a role. So that means if you give beta blockers to these patients, they will respond very well. So that means there is a possibility that adrenergic stimulation, which is playing a very major or pivotal role. Now, we saw about hypothyroidism and asthma. Now, let us talk about hyperthyroidism and asthma. And you will start wondering, is there any such association? A number of studies have identified an atopic background with elevation of serum IgE in 30% of patients with Graves' hyperthyroidism. And as a result, a warning should be given regarding the association of allergic bronchial asthma in hyperthyroid patients, and the evolution of which can be aggravated by beta blockers administered for the control of hyperthyroidism. So that's a very interesting finding which has been detected. Now, talking about hyperthyroidism and pulmonary arterial hypertension. So there are various clinical observations which has reported the association of hyperthyroidism, particularly Graves' disease, with pulmonary arterial hypertension, with over 70% of cases occurring in women. So this is more common in female compared to male. Its causes are not completely understood, and there are several mechanisms which could be involved. It could be secondary to an autoimmune process, though direct thyroid hormone through the direct or thyroid hormone action. The intervention of endogenous pulmonary vasodilators or vasoconstrictions on pulmonary vessels leading to such pulmonary arterial hypertension. Another theory is a decrease of pulmonary surfactant production and function and cardiovascular stimulation by the sympathetic adrenal system. So, and the pulmonary pressure drops with the institution of medical therapy for hyperthyroidism. So, moment you start treating or correcting the hyperthyroid state, the pulmonary pressures which has been seen to have gone up starts coming down. Now, we would go to the next subject, that is lung involvement in thyroid carcinoma. So, there are various types of thyroid malignancies are there, and thyroid malignancies are known to metastasis. So metastasis of thyroid cancer, uh, if we talk about papillary thyroid carcinoma, less than 5% of patients have distant metastasis at the time of diagnosis. But whenever it happens, lung is the most common site. So even though it is rare, when it occurs, it is in the lungs. Okay. Now, follicular thyroid carcinoma usually stays in thyroid gland but can spread to bone, lungs, and CNS. Medullary thyroid carcinoma, tumors which are more than 1.5 centimeter are likely to metastasize often to bone, lungs, liver, and CNS. And anaplastic thyroid carcinoma, nearly half of the anaplastic thyroid carcinoma patients have pulmonary metastasis at the time of diagnosis. So it's a huge number, with another quarter developing metastasis during the course of the disease. So large number of patients will have metastasis to the lungs, and that is in anaplastic thyroid carcinoma. So which is again, per se, it is a rare variety of thyroid malignancy, the commonest being papillary and follicular, and so is sometimes medullary, which you get it. Now, this is the X-ray picture showing thyroid carcinoma with lungs metastasis. So if you see, there is a tracheal deviation due to the tumor, which has been seen over here. The trachea has been shifted, which is very clear cuts showing over there. And there is a widespread pulmonary involvement, if you see, which is suggestive of the lung metastasis in a case of CA thyroid. Now, talking about the goiter. So, goiter is what? Enlargement of the thyroid gland. We know benign nodular goiter is a common disease which affects 5% of general population in non-endemic and 15% in endemic areas. And retrosternal goiters have the greatest part of their mass within the chest. So it all depends. So whether it is retrosternal or non-retrosternal. Now you must have seen such type of patients coming to you. This is diffuse hyperplastic goiter, or you can see the nodules. So this is like multinodular goiters which are there. Now, why? So per se goiters are benign, but there could be a possibility of airway compression due to goiter. So retrosternal localization of the enlarged gland is mostly associated with tracheal compression and displacement, causing varying degree of dyspnea. Obviously, once your air passages are compressed, the person will start getting breathlessness, especially more so on exertion. And in some patients with substernal goiter, dyspnea is primarily positional or nocturnal and occurs primarily during maneuvers that force the thyroid into the thoracic inlet, such as retching and bending. So, you need to be careful on such patients also. So, you must look out for whenever you feel for goiter. Is there any evidence of airway compression? So goiters, when tracheal compressions become severe, that means luminal diameter is less than 5 millimeter, the person may present with stridor or wheezing, and it can occur at rest. Upper respiratory illness may exacerbate upper airway obstruction. Cough may be present in 10 to 30% of patients and may be positional. Pain is unusual but a choking sensation which is common. And goiter can contribute to obstructive sleep apnea. We know it will come literally on its way for the sleeping down or patients to relax at that point of time. So it will block the air passages. So this is again a few imaging which shows the retrosternal goiter displacing the trachea in plain X-ray and a CT upper chest. You can see. So there is a displacement of the trachea which is happening because of the goiter. Now here if you can see the trachea has been shifted to one side. So that is a point which needs to be kept in mind. Of course, you don't have to ask for a CT scan to diagnose that. You can very well if the symptoms are present, if you can see clinically and get a X-ray chest, you still have the fairly good idea about it. Now, there's a very interesting articles which have come about tracheomalacia. So there is a article about high incidence of tracheomalacia in long-standing. This is experience from an endemic goiter region, and then there is a case report about 71-year-old female with giant goiter associated with tracheomalacia. So patients with long-standing goiter, even when benign, are more prone to develop tracheomalacia, and this can be serious, even life-threatening issues in a post-operative patients who require to undergo surgery, especially those who require a general anesthesia. There could be a difficulty in intubation in such patients, which also needs to be kept in mind. So, ladies and gentlemen, if I have to summarize, many thyroid diseases can lead to pulmonary problems, including hypothyroidism, hyperthyroidism, nodular goiter, and thyroid cancer. Hypothyroidism can reduce respiratory drive, causes respiratory muscle weakness, and can cause obstructive sleep apnea and pleural effusion. Hyperthyroidism is associated with increased ventilatory drive in response to hypoxemia and hypercapnia, which is perceived by the patient as dyspnea, particularly with exertion, and it may also cause respiratory muscle weakness and pulmonary hypertension. Papillary, follicular, and Hurther cell thyroid cancer can metastasize to the lung, and large cervical or retrosternal goiters can cause tracheal compression with symptoms of cough, nocturnal dyspnea, wheezing, and stridor. So you must keep it in mind. So, friends, now you understand what is the involvement of lungs in thyroid disorders. So, thank you so much for your patient hearing, and we would be happy to take up the questions if there are any. And I'm sure today's session was of interest in your clinical practice. Thank you so much. Thanks a lot.
Thank you so much for sir for your presentation. So we have some questions from our audience if you like to take that up.
Sure.
So sir, the first question from our audience is what are the association between immune related thyroid dysfunction and efficiency of immune checkpoint inhibitors?
No, so here it is the 2 points which has been taken into consideration. One is when we talk about autoimmune thyroiditis, that is the time we do check for, of course, the all the antibodies, and we we'll check for thyroid antibodies specifically at that point of time. And when we say we check the thyroid antibodies, it is antimicrosomal antibody and antithyroglobulin antibody. And the importance of this is that whenever these thyroid antibodies are positive, it is the condition is going to be a gradually progressive condition. It will not be the static one. It will not be recoverable conditions. So in especially we check it whenever we find that there is an entity of subclinical hypothyroidism. We always check for antibodies, so antibody check would be done in such subjects only. Thank you.
Thank you so much, sir. The next question from our audience is, what is the relationship between plasma antioxidant and thyroid hormones in chronic obstructive pulmonary disease?
Plasma antioxidants. So
Yes, sir.
antioxidants per se will not be have a direct role to play in such patients. Of course, there has been the role of surfactants which has been described, and especially that also during the maturation of the lung, but not for per se in the COPD patients also. Thank you.
Thank you, sir. The last question from our audience is, what are the challenges in diagnosis and biomark testing of RET altered lung and thyroid cancer care?
Can you repeat the question? What are
Sure, sir. So the last question was, what are the challenges in diagnosis and biomark testing for RET altered lung and thyroid cancer care?
Okay, so obviously, if you have the lungs and thyroid malignancies, which is there, and you need to diagnose, so there are a couple of ways by which you can diagnose. Of course, the CT chest with a contrast will be helpful because of to pick up the lymph nodes as well as the parenchymal pathologies. It will be helpful, but if you want to see the direct involvement, then the PET CT, because sometimes their patient might have a non-specific infiltrative shadows in the lung, which cannot be attributed to because of the malignancy of the thyroid. So the PET whole body PET CT will be helpful, and if that shows that there is a tracer uptake in the thyroid, as well as there is a pressure uptake which is there in the lungs, so you know that there is a lung malignancy, or lung malignancy you have confirmed with the histopath, and then you get a PET CT done, and then there is a uptake in the lungs. It would be highly suggestive of that these are the metastasis which has happened from the primary thyroid malignancy with involvement of the lungs. Thank you.
Thank you, sir. That's all from our audience. Before concluding today's session, sir, any last remarks from you?
So, ladies and gentlemen, please keep your eyes open. Eyes don't see the things which mind don't know. So, we must aware about the correlation between the lungs or the respiratory system and the thyroid dysfunction. And lungs have been one of the commonly involved organ in various thyroid conditions. So, please keep it in mind. Thank you so much.
Thank you so much, sir, for joining us today. With your permission, I would like to just conclude today's session, sir.